Hello and welcome to the Tuesday 9:30 a.m. Pacific Coast Time ICAAC live session. Today, coming to you from San Francisco. We'll have 3 sessions altogether today, and this is the last day of these sessions. I'm Jeffrey Fox, your host today. I'm the features editor of Microbe, the monthly magazine of the American Society for Microbiology. ICAAC is the annual infectious diseases meeting of ASM, that is the American Society for Microbiology. And in this session, we'll be talking about antibody therapies for Clostridium difficile infections. Before I introduce our guests for this session, let me remind those of you who are following us on the web that you can use hashtag ICAAC or @ASM Newsroom to send questions to us. For those of you in the room who might want to ask questions, and we invite you to jump in just about any time once our discussion gets going. Please wave a hand, wait for a microphone, and then give us your name and institution, and follow with your question. All right, so enough with that introductory material. I want to introduce our guests, and to my immediate left is Sylvia Wong, who is a graduate student at the Donnelly Center for Cellular and Biomolecular Research at the University of Toronto in Toronto, Canada. And seated to her left is David Humphreys, who is from UCB Pharma in Slough, the United Kingdom. Slough is outside London. Let's let Sylvia, if you would, start by giving a summary of your findings, and then we'll have David follow her, and we'll continue with the discussion. Go ahead.
Okay. The lab, or my lab in Toronto, specializes in generating antibodies for a whole wide range of antigens. And some of these antigens, for example, are receptors for important for cancer cell proliferation and metastasis. My research is to generate antibodies against the toxins produced by C. difficile. Now, we all know that toxins A and B are the major toxins produced by C. difficile and causes the symptoms of the infection. But there is an additional toxin called CDT, and we really don't know the role in infection. And so my project is to block all 3 toxins and to see if there's a synergistic inhibition and also protection against the infection. And using phage display technology, I am targeting the receptor binding domain of the toxins and as well as the receptor for CDT. So the receptor of CDT, called LSR, which stands for lipolysis stimulated lipoprotein receptor, is also recently discovered by my collaborators, Dr. Thijn Brummelkamp and Dr. Klaus Ektoris from Germany and Netherlands. They found that CDT receptor is LSR. And also using Select-Seq, which is a new methodology developed in our lab, we can screen for antibodies that are for proteins that are directly on the cell surface of mammalian cells. And this is important, especially for membrane proteins like LSR, which is difficult to purify. And as well as we can find antibodies that are specific for proteins that are naturally expressed on the surface. So overall, really, my goal for my project is to understand the role of CDT, and as well perhaps use these antibodies to as a potential therapeutic to relieve the symptoms of C. difficile infection and to provide, allow the natural microflora levels to become normal and outcompete C. difficile.
Okay, now to understand some of what Sylvia just described, we'll take some work, and we'll try and fill in some background about the nature of C. difficile infections as we go along, because that will help to explain what she's trying to do. So David, if you would give a summary of your work,
Sure.
and then
Okay.
we'll...
So I work for UCB Pharma, which is a European biopharma company based with research in UK and Belgium. And one of the areas of expertise of UCB research is the development of therapeutic antibodies. So some years ago, we spotted that the C. difficile problem was really ripe for intervention with antibodies. And primarily that's because it's the toxins, which have been shown in multiple studies in lots of different ways, which cause symptoms. And that's a little bit peculiar, and at the moment all the best therapies are antibiotics, which actually kill the bacteria, and so only indirectly influence the toxin. And so, of course, our aspiration is that by combination of good antibiotic and good neutralizing antibodies, that will increase the lot of patient outcomes. And so we've developed some neutralizing antitoxin A antibodies and antitoxin B antibodies and made them as a mixture. And we've tested those in a whole host of in vitro assays, and I'll be talking about that this afternoon. We also did an infection study, which is where hamsters are made sensitive to infection for C. difficile, and then the hamsters were protected with antibody alone. So just to be clear, they're not antibiotic and antibody, just antibody alone. So that's a protection that can be given to the animals by neutralizing the effects of the two toxins. And so we're hoping to find a partner for those and take those through into the clinic in due course. I think the other interesting thing about the data that we're going to present, which is of interest to the wider world outside of our own antibodies, is we did a head-to-head comparison in those in vitro studies and in vivo studies by synthesizing the antibodies which are the most advanced in clinical trials. So those are now with Merck, and it's called MK3415A, and they've had different names over the years. And those in vitro and in vivo comparisons, I think, give a lot of information about the disease in general and those antibodies in particular. So I think there's kind of something for everybody in the results that we're going to present.
Okay, good. So those are helpful summaries. And then let me invite the two of you to, and maybe we should give a little bit of background about the nature of C. difficile and who's susceptible to it, or what population group is most affected by these infections, and sort of the nature, what you're trying to accomplish by using antibodies to neutralize these toxins, because the toxins are causing severe diarrhea. Yep. That's the first thing to say, but sure. But maybe you could elaborate on that.
Okay, so perhaps I can speak to that a little bit. So, I mean, it's a major clinical problem. There have been many talks at this conference that describe that, and actually the problem is kind of morphing into some respects a more serious one, in that the severity of the way patients are affected is changing. So patients get diarrhea, and that can be typically from 3 to 15 bowel movements per day. And that can go on unabated for many days unless intervention with antibiotic. Even with treatment with antibiotic, the kind of time to cessation of diarrhea can be not so quick. Historically, it was 3 to 5 days. I heard in the conference this week, it's now more like 6 to 10 days when you start to see cessation. People can have other symptoms such as fever, and there are various markers of severity of disease such as elevated white blood count. It also kills people. So, you know, if you're a patient with C. diff, diarrhea is pretty unpleasant, but the palpable risk of death from diarrhea is, you know, something we don't associate with diarrhea in the Western world. And for those that are cured, i.e. their diarrhea stops for 2 or more days, the risk of recurrence is now very high. And we've heard many talks in the conference already that the risk is generally at least 20%. It can be in certain patient subgroups and subpopulations much more than 30%. So a very serious problem, and all the time that you're in hospital, risk of spread, because the bacteria produce spores. You know, if you're in a bed next to someone with C. diff, you wouldn't be feeling perhaps so good about your prospects either. So it's still a really serious problem, and I think a combination of antibiotic and antibodies, which is what we're both focused on, and it's got potential for the future.
Right, right. Well, I think that helps to put things in perspective, and it's probably worth adding that it's mainly an elderly population that's especially susceptible to C. difficile. Okay, so with that added background, let's talk some more about the details, because both of you are working with antibodies to the toxins, but you've derived these antibodies in very different ways, and I think it would be worth describing, not in great detail, but to give some idea of the differences in strategy and outcome. You have different products or candidate products to look at. Okay. So if you both take turns here and describe what you've done.
Sure. So the antibodies that I work with are fully synthetic, but we use bacteria to amplify the amount of this antibody. And these antibodies are actually displayed on phage, which is a virus that infects bacteria, and it can be amplified. And so the phage is displayed this antibody fragment that can bind to different antigens, and we incubate that with a particular antigen, like let's say toxin A, and then we wash off the unbound non-specific antibodies, and then we take off the bound ones, and then we amplify back into E. coli, and so it goes 3 or 4 rounds of this amplification, and this kind of mimics the kind of the immune system to enrich for the specific binders for the particular antigen. And so that's what we use for our antibody generation.
Okay, and the antibodies, you have separate antibodies for each of the toxins, but in one case you have an antibody, I think you said earlier to me, that has dual activity, right? That recognizes two of those toxins.
Based on our assay, our data, we found a few antibodies that bind to both toxin A and B, although we still have to validate this assay on cells and in animal models. Okay,
and David?
So we used an approach of immunizing animals. In this case, it was rodents and rabbits. And one of the expertise in UCB Pharma is it's kind of a B-cell rescue approach. So you can pan billions of B cells from...
B cells, just to remind people, are the antibody-producing cells of the immune system of those host animals.
Absolutely. So thanks for that clarification. So we can find the B cells that both bind the toxin and with some assays also those that are neutralizing. So we can really kind of sort the wheat from the chaff. And then we humanize those in a kind of traditional manner. So humanization is a technique which basically makes the sequence of the antibody very much more like human than the original rodent or rabbit sequence. I think the key strength that was the assays that we used to try and identify the activities in those antibodies. For example, we got a lot of antibodies that were binders but not neutralizers. I should say that actually we decided to focus the C-terminal domain of the toxin. For those that don't know, the C-terminal domain is the part of the toxin A and B which binds to cells. So this is the first event of the toxin going about its business. So we wanted antibodies that neutralized in that region. And we searched for antibodies that bound to that region and were neutralizers. Like Sylvia, actually we searched, one of the dreams was to get a monoclonal antibody that neutralized both toxin A and toxin B. We tried very hard with lots of different strategies, which won't go into here. And essentially, that wasn't possible. We got antibodies that bound toxin A and toxin B, but they were never neutralizers of A or B.
I see. So let's see if I can ask this question, if this is the right question to ask. But that C-terminal domain is the same for both toxins, or is there variation between the two of them?
There's quite a high level of sequence difference between toxin A and toxin B. The overall global structure, the fold of the protein is the same, and its function is the same, but we knew before we started that the sequence identity or the sequence similarity between toxin A and toxin B was pretty low, and that probably explains why you can get binders to do both, but not neutralizers.
Right, right. Unless you had a double-headed antibody.
Like a bispecific antibody.
Yeah.
Yeah, absolutely, and that's an approach that I'm sure people are considering.
Okay. No, so there's some really difficult or fancy technology here on display. Let's see. Let me just add the toxin. The 2 toxins or 3 toxins from C. difficile need to go into cells of the host, to cells lining the epithelium of the gut, right, for them to exert their toxic effects. They're no good if you can keep them outside.
Absolutely.
Outside the host cells, then you've done part of your job.
Yeah.
So why then do you need a neutralizing antibody? Why can't, if you just bind it up and keep it outside, why wouldn't that work?
Well, it's not to say that it couldn't work, and if you think about a natural polyclonal response, I'm sure there will be antibodies in there that are non-neutralizers or poorly neutralizing, but for a therapeutic, when it's a monoclonal, you want to pack as much punch as possible in your dose, and the concept of administering a non-neutralizing antibody really doesn't hold a lot of water for a therapeutic. Notwithstanding that antibodies that bind to a toxin actually could potentially increase the half-life in the circulation if any made it into the bloodstream, and that's not something that you really want either.
No, right. I would guess you wouldn't want these toxins circulating. No, that doesn't sound like a good outcome. I agree. Sylvia, so far the testing of your antibodies you haven't tested them in animals, right?
No, not right now.
So how far along are you with evaluating these antibodies?
So now we have the binders, and I'm currently doing a affinity test to actually get the kinetics of how tightly the antibodies are binding to the toxins. And then currently, with the collaboration of someone in Toronto, we are testing on cells, just in tissue culture, and then we're going to head forward after the outcome of this test.
So there is a way to test potentially how effective these antibodies are by just in cell culture. I don't fully understand how that works, but
so a collaboration with Dr. Melnick's lab, they have recombinant the full-length toxin, and then you can introduce these toxins onto cells, and you can see cell death, you can see cell rounding. That is characteristics of these toxins, what they do. And so if we prevent the cell death or the cell rounding, then is an indication that it is doing its job.
It's likely to work in an animal. And so let me use that as a segue to ask a little bit more about the hamster testing that you've been doing, David, where, first of all, I'm wondering how, C. difficile is not a typical pathogen of hamsters, I suspect, and so maybe you could describe a bit of how you think how valid this way of evaluating the antibodies is.
So I think the first thing to say is that the hamster infection model is the standard model used in the world for the last 20 or 30 years. Whether it's the very best model that we could have, I think is debatable. And the reason that hamsters are used is because of all the animals tested, and various rodent species and rabbits were tested over the years. Hamsters they take the infection, i.e. that the C. diff can grow in their gut. And moreover, they're acutely sensitive to the effects of the toxin, both toxin A and toxin B, but for hamsters, probably they're particularly sensitive to toxin B. So basically, it's a pretty crude model in that it doesn't represent human disease very, very closely, but it's pretty robust and it works 10 times out of 10. And actually, if you can get any drug which protects hamsters, it's probably a pretty good starting place, because the disease symptoms they suffer are so acute and so overwhelming that it really represents I think the very sharp end of infection, as it would be in humans.
Okay, and I wanted to ask a specific question about the experiments that you did, where you described the results as protective of the animals, and which suggests to me that you were infusing antibody before they were infected.
Yep.
Will things work the other way around? If they're infected, can you rescue them with the antibodies? Wouldn't that be a more stringent test?
It would be a more stringent test, and we haven't done those experiments. One of the reasons is that, at least in the literature, it shows that those experiments are very, very difficult to do for a number of reasons, but one of them is that the symptoms are so acute in hamsters, and the timing is so kind of abrupt, that actually, to get sensible experiments, you need to use a lot of animals, and that's something that we really don't choose to do at this stage.
All right, so for technical reasons more than anything else, that kind of experiment.
Yeah, you need very large group numbers of hamsters, and that's got all sorts of practical and ethical questions hanging over it.
Oh, yeah, no, I would agree with you there. But and how do you administer the antibodies? Because the trouble, the symptoms and the infection are all in the gastrointestinal tract.
Yeah.
But I would think if you administer the antibodies by mouth to the animals, that it wouldn't get to where it needs to go.
Yeah.
It would be digested first. So you've got some challenges there in terms of delivery.
Yeah. So the antibodies in humans, in the phase 2 trial that was conducted to date with other antibodies, it was given by IV infusion. I'm sure in the future that will move towards subcutaneous and other routes of administration. And you're right that the concept of giving the antibodies orally is a nice one, and actually one that's been tested and essentially failed. One of the reasons is passage through the gut. If you've got 3 bowel movements a day or 15 bowel movements a day, that's a very big difference.
Oh, I see. It comes and goes.
In the residence time,
yeah.
absolutely. But actually, from a biological standpoint, the really interesting thing which has come out in the last few years is that the antibodies that protect animals and humans against gut infections are IgG. So for those that know their antibodies, there are different classes and isotypes, and IgM and IgA are those that are well known to protect the mucosal surfaces. But actually, what really does it is IgG.
Which is something of a paradox, because we are talking about a mucosal surface, and yet IgG, it's not supposed to be the one that works here.
Absolutely.
But
so I think in C. diff patients, it's almost it's not a problem, because one of the signatures of the disease is damage to the gut, and so serum components, including IgG and albumin, leak out into the gut. So antibody administered IV will get into the gut lumen without any problem. But actually, for those areas of gut which are not damaged, there's some really nice papers that show that there is a receptor for IgG in gut lumen surfaces, and actually can kind of put the antibody, just sample the environment and bring that antigen back and actually educate the immune system. So that's a really exciting part of the future for antibodies, that a very good antibody might ultimately educate the immune system of the patient.
So just to pursue this one step further, if you can deliver you are delivering the monoclonal antibodies, or the antibodies, let's say, through the circulatory system, with the raging symptoms, will you still have troubles with getting appropriate dosage? And because once you get it to the right site, there still is all that commotion from the diarrhea, from the symptoms that the patient is experiencing. Will you be diluting out the antibodies and still face that trouble of having a dosage problem?
Sylvia, do you want to? Do you want to speak to that?
So it is a problem in finding the right dosage that for a particular patient, let's say a patient that has a mild symptoms versus a very severe symptoms. So that's something that's ongoing right now too.
I think there was one important data point in the phase 2 study that was conducted by other investigators in infected patients, and the pharmacokinetics of the antibody was essentially normal. So there was a very large dose of antibody given, but I think really what that suggests to us is that the antibody is just not lost wholesale into the gut. In fact, the coverage was a half-life of an antibody, an IgG is typically 3 to 4 weeks, and it was in that kind of ballpark.
Okay. And I had another question that occurred to me a bit earlier, and that is, David, you said something about the nature of C. difficile infections, that they seem to be more intense, more severe. Now, does that have anything to do with changes in the toxin? I mean, do people know why that's occurring? And if it does involve the toxin, it could undermine the value of the shelf life, say, of this set of antibodies,
Sure.
if the toxin is changing in some way.
Sure. So one of the clear links that's in this meeting and previously is that one particular strain, which is called ribotype 027, or NAP1 or BI, it's a different nomenclature for the same thing, is associated with poorer outcomes in patients, and actually is more difficult to cure and has worse recurrence levels when treated with the very best antibiotics that are around at the moment. There are sequence differences between those toxins and others, but the exact link between sequence and function is not known. And of course, the infection through an organism is very much more complex than the sequence of the toxin. There are other pathogenicity traits which are starting to be understood now, sporulation and growth properties and those sorts of things. But it's clear that an antibody needs to be able to neutralize toxin from different species, and we've tested that, and so have others. And that's a really important part of a drug development.
I'd like to comment on that too as well. That NAP1 and the strain produces all 3 toxins, so perhaps maybe the 3rd toxin may have a role in the severity of the strain.
So having an antibody to the 3rd toxin will be part of the strategy for having a better package of
it may or may not. I'm still that's the research of what I'm trying to do.
Okay.
I mean, it's a really interesting part of Sylvia's work that we'll be able to try and answer that question in a way that's not been done before, to see how important CDT, the 3rd toxin, if you like, is to disease in animals and humans.
Okay. Well, let me see. We don't have any questions in the room, it looks like, and no questions on the internet. Well, so let me invite both of you to share a final thought or something that you'd like, maybe something you didn't cover, or emphasize something you've said already before we finish our discussion.
Sure. Can I go first?
Yes, I should mention that these synthetic antibodies, the beauty of them is that we can actually tweak the specificity or the affinity of the current antibodies and just improve the binding of it. And so that's what I like to comment on.
Yeah, I think the finishing point for us is we hope that if we can bring these antibodies into clinical development, we might be able to improve the prospects of patients infected with all types of C. diff around the world, and actually save healthcare systems a lot of money, principally because we're aiming to moderate disease, so there are shorter hospital stays and shorter durations of diarrhea.
Right. And of course, as soon as I said that was going to be a final comment, it turns out that prompted someone to ask a question. So at least maybe 2 questions, but first the man with the microphone. If you'd identify yourself and then ask the question.
Sure. Jared Silverman from Cubis Pharmaceuticals. Just to follow up on the conversation regarding antibody penetration to the site of infection, in diseases like meningitis, what one typically sees is that early in the disease, when there's a lot of inflammation, drug penetrates well to the space, and then paradoxically, as the infection begins to cure, the ability of the drug to get there becomes weaker and weaker. Would you anticipate a similar effect with the antibodies, that early on you'd get much better penetration, but that as they worked, they'd actually become less able?
I think, it's pure speculation. Of course, the amount of damage to the gut in animals and some humans is so prolific. I think there are very measurable levels of albumin and IgG in the gut lumen. So how quickly that stops and how abruptly that stops, is it an on-off switch? I couldn't begin to think.
We have another question.
Ben Yanko, Infectious Diseases, Tampa, Florida. I'd like to commend you for this extremely interesting presentation. Do you have any sense as far as the life of these antibodies, or how long it might last as far as its effect? Because it seems to be, it will be a passive immunization or a passive transfer. So it would be a short-lived thing, and for those individuals, for patients, for instance, in the clinical setting where you will have this in a recurrent basis, are these going to be short-lived? Are these antibodies short-lived, or do they persist? Or would you have any idea at this point?
So currently, right now, these antibodies are about a month half-life. And so it is a bit short-lived, but the purpose of these antibodies is to relieve the symptoms until the commensal of our gut goes back to normal and outcompetes C. difficile. And
the half-life is typically 3 to 4 weeks for an IgG. Of course, the important thing is that means there's a significant amount of antibody around at 8 weeks and still measurable amounts at 12 and 16 weeks. And you can see that in newborn babies, the protective and interfering effects of maternal antibodies go on for, in fact, I heard just in this room a few days ago, for up to a year. So I think long-lived is all we can say, but how long-lived, I think, depends on the dose and the potency of the antibodies.
Well, that does raise a question. Another question, though, is that if you have antibody persisting, if you are not treating the infection with an active and reliable antibiotic, it seems to me you could have symptom-free patients who still are infected and might still be shedding. They would be a lot more comfortable, but they would still be potential spreaders of the infection. And so trying to work this out for clinical use may be more complicated, because it seems you need an effective antibiotic to go hand in hand with this treatment. Absolutely.
I think we can only contemplate using antibodies in addition to best of care vancomycin or other antibiotics. That's quite clear. The aim is to hit both sides of the disease, to neutralize the toxin and to reduce the bioburden of the bugs that are actually producing the toxin in the first place with antibiotic.
Okay. Well, thanks very much. I want to thank Sylvia Wong of the University of Toronto and David Humphreys of UCP Pharma in Slough, the United Kingdom again. And I'd like to remind people that we have 2 more sessions of ICAAC Live coming up today. One in about a half hour that will be on H3N2 influenza, and then our last session on the emerging role of social media in public health, and that will be in about 90 minutes. Thanks very much for joining us. Come on back in a half an hour. Thank you.
Explore the fundamental role of microbes in the natural history of our planet with Microbes in Evolution, the world that Darwin never saw. Available at estore.asm.org.